So in utero, fetal blood was shunted away from the lungs, but when birth occurs, the pulmonary vasculature must be fully perfused for this purpose. Clamping of the umbilical cord causes a rise in blood pressure, which increases circulation and lung perfusion. Remember, when you see that word perfusion, that just means how much that organ is being fed, the oxygen, vitamins, nutrients, all the good stuff they need, right? Does this need to be bigger? Surfactant, very important. The alveoli of the term infant's lungs are lined with surfactant. Lung expansion depends largely on chest wall contraction and adequate surfactant secretion. Remember, surfactant, this is what allows those lungs to expand appropriately. Surfactant lowers surface tension, therefore reducing the pressure required to keep the alveoli open with inspiration and prevents total alveolar collapse on exhalation. Remember, the alveoli, that's where gas exchange takes place. So this thereby maintains alveolar stability. Once respirations are established, breaths are shallow and irregular, ranging from 30 to 60 breaths per minute, with periods of breathing that includes pauses in respirations that last about 20 seconds. Apneic episodes longer than 20 seconds are abnormal and should be evaluated.
Why does that happen?
No clue.
The 20-second of them not breathing, I don't know. Newborn infants are by preference nose breathers. Therefore, cyanosis or asphyxia can occur with nasal blockage. Signs of respiratory distress. Signs of respiratory distress can include nasal flaring, intercostal or subcostal retractions, that's indrawing of tissue between the ribs or below the rib cage, or grunting with respiration. Suprasternal or subclavicular retractions with stridor or grasping most often represents upper airway obstruction. Seesaw or paradoxic respirations, remember that word paradoxic means opposite, or paradoxic respirations instead of abdominal respirations are abnormal and should be reported. A respiratory rate, remember it's supposed to be 30-60. A respiratory rate of less than 30 or greater than 60 with the infant at rest must be evaluated. So obviously, if they're irritated and they're crying, the respiratory rate is going to be increased. The heart rate is going to be increased. We understand that, but at rest, it's less than 30 or higher than 60 that needs to be reported. Changes in the infant's color can indicate respiratory distress. Normally, within the first 3 to 5 minutes after birth, the newborn's color changes from blue to pink. Acrocyanosis, the bluish discoloration of the hands and feet, this is normal within the first 24 hours. Now notice, the book says acrocyanosis, not central cyanosis. So that bluish color of the extremities in that first 24 hours, this is normal, guys. Now, if you're seeing a bluish discoloration of the face or the trunk, that's central cyanosis. Now we have a problem. Look at what it says. Acrocyanosis, the bluish discoloration of hands and feet, is a normal finding in the first 24 hours after birth. Transient periods of duskiness while crying, because it takes energy to cry, right? The more energy you use up, the more oxygen you use up. Transient periods of duskiness while crying are common immediately after birth. However, central cyanosis is abnormal and it signifies hypoxemia, not enough oxygen in the blood. With central cyanosis, the lymph and mucous membranes are bluish. So make sure you guys know the difference between central and acrocyanosis, okay? All right, moving on, cardiovascular system. Circulating prostaglandin levels also have an important role in closing the ductus arteriosus. And what did I write down here? I wrote, okay. I wrote that's the hole between the pulmonary artery and the aorta. In case anyone had a brain fart, there's a reminder. In term infants, it functionally closes within the first 24 hours after birth. That's what's supposed to happen.
Wait, what'd you say the writing?
Oh, I wrote, it's the hole between the pulmonary artery and the aorta. In term infants, functionally closes within the first 24 hours after birth. Permanent closure usually occurs within 2 to 3 months, and the ductus arteriosus becomes a ligament. Let's move on to the thermogenic system. Newborns attempt to stabilize their core body temperatures within a narrow range. Hypothermia from excessive heat loss is a common and potentially serious problem. And on the side here, I wrote no shiver. So they can't, you know how if we're cold, we'll start to shiver. We'll try to warm ourselves up, right? They can't do that. So we have to be very intensive about making sure that they don't lose heat. Thermogenesis. In response to cold, the neonate attempts to generate heat. That's the thermogenesis by increasing muscle activity. Cold infants may cry and appear restless. Because of vasoconstriction, the skin can feel cool to touch and acrocyanosis can be present. Adults are able to produce heat through shivering. However, the shivering mechanism of heat production is rarely operable in the newborn unless there is prolonged cold exposure, which we don't want to happen. Newborns produce heat through non-shivering thermogenesis, triggered when the skin temperature decreases to less than 95 to 96 degrees. This is accomplished primarily by metabolism of brown fat. You guys need to know this. This is unique to the newborn. Let's jump to the intestinal system. The gastrointestinal system, 517. Intestinal flora or gut microbiota are established within the first week after birth, and normal intestinal flora helps to synthesize a vitamin K, folate, and biotin. I skipped this safety alert, so let's look at the safety alert right here. Noting and recording the first voiding are important. An infant who has not voided by 24 hours should be assessed for adequacy of fluid intake, bladder distension, restlessness, and signs of discomfort. The neonatal healthcare provider should be notified. All right, let's talk about stools. You need to know about meconium. Meconium. This fills the lower intestine at birth. Meconium is greenish black and viscous and contains occult blood. Most healthy term infants pass meconium within the first 12 to 24 hours of life, and almost all do so by 48 hours. It's been seen on NCLEX. You absolutely need to know that. That's that first stool. Again, meconium, that's the first stool. It'll be dark or olive green in color. Passage of meconium should occur within the first 24 to 48 hours. Let's move on to bilirubin synthesis. The liver is responsible for the conjugation of bilirubin, which results from the breakdown of RBCs. When RBCs reach the end of their lifespan, their membranes rupture and hemoglobin is released. The hemoglobin is phagocytized, that means it's basically eaten up. It's phagocytized by macrophages. It then splits into heme and globin. Why is this important? When the levels of unconjugated bilirubin exceeds the ability of the liver, remember the liver is responsible for conjugating it, plasma levels of bilirubin increase and jaundice appears. Jaundice is the visible yellowish color of the skin, and sclera is likely to appear when the total serum bilirubin exceeds 6 to 7. So when the bilirubin number is higher than 6 to 7 milligrams per deciliter, the patient's more likely to be jaundiced. The degree of jaundice is determined by the serum total bilirubin measurements, because remember, that's what's causing that yellowish color. Traditionally, newborn jaundice has been categorized as either physiologic or pathologic. Notice I put a happy face under physiologic because that is normal. I put a sad face under pathologic. It's pathologic, you have a problem. You guys have to know the difference. Among the factors that increase the risk for hyperbilirubinemia, preterm birth is the most significant factor. That's the highest risk factor for having all that bilirubin in the blood. Prematurity affects liver and brain metabolism and albumin binding sites, placing preterm and late preterm infants at greater risk for hyperbilirubinemia. Look at this box, risk factors for severe hyperbilirubinemia. Again, being preterm, that's number 1. Breastfeeding, especially if exclusively breastfeeding and weight loss is excessive. So what happens is, if they're only breastfeeding, but they're losing weight, most likely they're not latching the way that they're supposed to, and they're really not getting enough of that breast milk, okay? Our HABO incompatibility, polycythemia, being of Asian or Native American race, bruising related to birth trauma or previous sibling who received phototherapy. And we're going to talk about phototherapy in a minute, but that's one of the treatments for the jaundice caused by the hyperbilirubinemia, okay? So let's start with physiologic jaundice. That's the happy face, that's the good kind, okay? Physiologic or non-pathologic jaundice. This occurs, it appears after 24 hours of age and usually resolves without treatment. Your key, guys, it appears after 24 hours of age. After, okay? Look at the safety alert. The appearance of jaundice during the first 24 hours of life or persistent beyond the ages previously delineated usually indicates a potential pathologic sad face process that requires intervention. So let's get to the sad face, pathologic jaundice. Pathologic or non-physiologic jaundice is unconjugated hyperbilirubinemia that's either pathologic in origin or severe enough to warrant further evaluation and treatment. Jaundice is usually considered pathologic or non-physiologic if it appears within 24 hours after birth. The total serum bilirubin levels increase by more than 0.2 milligrams per deciliters in an hour. The TSB is greater than the 95th percentile for the age in hours. Direct serum bilirubin levels exceed 1.5 to 2 milligrams per deciliter, or clinical jaundice lasts more than 2 weeks. I know that book says all of that, but for testing purposes, if they want to know, if you know the difference, they're going to be asking you about before or after that 24 hours, okay? Jaundice related to breastfeeding. Excuse me, guys. Look at this. Breastfeeding does not cause the jaundice, okay? Rather, it's a lack of effective breastfeeding that contributes to the hyperbilirubinemia. If the infant is not feeding effectively, there's less caloric and fluid intake, ongoing weight loss, and possible dehydration. Hepatic clearance of bilirubin is reduced, and it makes sense. If that baby's not getting enough breast milk, they're losing weight, they're not going to be clearing out the bilirubin the way they're supposed to. So we're gonna see increased levels in the blood. It makes sense. Integumentary system. So does breastfeeding cause hyperbilirubinemia?
Well,
Very good. All right, integumentary system. After 35 weeks of gestation, the skin is covered by vernix caseosa. This is a cheese-like whitish substance. When you see cheese-like whitish, I want you to think of vernix caseosa, okay? It's a cheese-like whitish substance that's fused with the epidermis and it serves as a protective covering. It has antimicrobial properties. This is normal. I know it makes the baby look weird, but it's actually a good thing. It's normal. Sweat glands. Distended small white sebaceous glands noticeable on the newborn face are known as milia. And here's a picture. Okay. That is normal. Nevus simplex, also known as salmon patches. Telangiectatic nevi, stork bites, or angel kisses. This is the result of superficial capillary defects and occurs up to 80 newborns, up to 80% of newborns. That's normal as well. Let's move on to the reproductive system. Males. The foreskin adheres to the glands and is not fully retractable for 3 to 4 years. This is important. You have to teach the parents, do not try to force the skin back because it's not going to be fully retractable until that child's around 3 years old. Usually it's 3. Like 10, 3 to 4 years old, okay? The position of the urethra, that is the hole that should be at the tip of the penis, right? The position of the urethra should be at the tip of the penis. With hypospadias, the urethral opening is located at an abnormal position. At any point on the ventral surface of the penis, surface from the glands to the perineum. Now, if the urethral opening is located on the dorsal surface of the penis, that is known as epispadias. Talk about hydrocele. Hydrocele. This is caused by accumulation of fluid around the testes. Hydroceles can be easily transilluminated with a light and it usually resolves without treatment. Swelling of breast tissue. Swelling of the breast tissue in term infants of both sexes is caused by hyperestrogenism of pregnancy. This is a normal finding. This finding has no clinical significance. It's going to decrease over time. Skeletal system. Caput succinium is a generalized, easily identifiable edematous area of the scalp. Here's what you need to know about it. The edematous area present at birth extends across the suture lines of the skull. Extends across the suture lines of the skull. Now, cephalohematoma. Cephalohematoma, this is a collection of blood between the skull bone and the periosteum. It does not cross a cranial suture line. Cephalohematoma does not cross a cranial suture line. You're going to be expected to know the difference between the two. We've talked about this before. You're seeing this again. The infant's going to be examined for developmental dysplasia of the hips. Signs of this developmental dysplasia of the hips are asymmetric gluteal and thigh skin folds, uneven knee levels, a positive ortolani or positive Barlow test. The hips are inspected for symmetry. Gluteal and thigh skin folds should be equal and symmetric, and the legs should be of equal length. And remember, the healthcare provider is the one that's going to be checking for that. I mean, you can do visual inspection, but you're not going to do that physical examination. You're just going to assess the healthcare provider. Safety alert, this is on this has been seen on Plex. Make sure you know this. Only expert examiners, such as physicians and nurse practitioners, should perform the Barlow test and Ortolani maneuver to assess for DDH. Matter of fact, this is not only on NCLEX, it's also on the exam. For the, was it ANP and I forgot the other organization, the test for NP, but those two exams, they're on that as well. So make sure you know that. An unskilled examiner can cause injury to the newborn. Assessment of newborn reflexes. Okay, the rooting and sucking reflex. How do you elicit that reflex? You touch the infant's lip, cheek, or corner of mouth with the nipple or finger. Excuse me, with the nipple or finger, yes. The infant's gonna automatically turn their head towards the stimulus and open their mouth. All you gotta do is like touch your cheek and they're gonna turn towards that way and open their mouth. Look at the comment, parental guidance. Avoid trying to turn the head towards the breast or nipple. Allow the infant to root. All you gotta do is tap them on the cheek. They're gonna turn their head and open the mouth. Allow them to root. Response usually disappears after 3 to 4 months, but it can persist up to a year. Grasping, the palmar and plantar grasp. You have to know the difference between the two. The palmar is you place a finger in the palm of the hand, and plantar, you place a finger at the base of the toe. And for both, you expect them to curl downwards, the finger or the toe. Next, the Moreau reflex. This is a famous one. So you hold the infant in a semi-sitting position, allow the head and trunk to fall backward to an angle of at least 30 degrees. Here's what you expect to see. Symmetric abduction and extension of the arms. You see what the baby's doing right here? They feel like they're falling and they should extend out like that. The response is absent by 6 months of age. If you're still seeing this after 6 months, you should suspect some type of neurological deficit, and this has to be reported. Next, the stepping or walking reflex. You hold the infant vertically under arms or on trunk, allowing one foot to touch table surface. The infant will simulate walking. They're not walking for real, but they'll simulate walking. And the response is normally present for 3 to 4 weeks. The crawling reflex, place the newborn on the abdomen. The newborn makes crawling movements with the arms and legs. They're not really going anywhere, but they make the movements as if they're crawling. And the response should disappear around 6 weeks. This one's a big one. It's been seen on NCLEX many times. Make sure you know it. The Babinski reflex, also known as plantar. You see how the arrows go? So you start with your finger here, and you just touch them along. You start down here, and then you go off the side. And look what it says, to listen reflex. On the sole of the foot, you begin down here at the heel, and you stroke upwards along the lateral aspect of the sole, then move finger across the ball of the foot, just like you see here. Here's what you expect to see happen. All toes hyperextend. See how it's going backwards? They hyperextend with dorsiflexion of the big toe. This is recorded as a positive sign. We expect to see that Babinski reflex. And you see how these flare out? Absence of this reflex requires neurological evaluation, and this should disappear after about a year. Crying. Crying is a language an infant uses most often to communicate needs. It can signal hunger, discomfort, pain, desire for attention, or fussiness. Infants may cry in response to environmental stimuli such as cold, being overstimulated, or being held by multiple persons.
The page you're on? 534.
Oh, sorry, 534. Responsiveness of caregiver to crying creates trust as the infant learns to associate the caregiver with comfort. So